Мы приглашаем Рольфа Морхарта к нам. Я, наверное, детально не буду описывать презентацию, потому что как раз специалист по этому вопросу Рольф. Я передаю... Так, микрофон, наверное, этот? Этот? Да.
First of all, hello everybody. Unfortunately, my Russian knowledge of the Russian language is so poor that it's very difficult for me to pronounce good day, hello. I just use the short form privet, so I don't know if I can say to you privet, but I would do it. Okay, let me say first of all many thanks to Ladislav. I don't see. Where is he? Is he away? Okay, just for a moment. I think he's the reason that I'm here. And to Svetlana Urbanova, they both were contacting me, but I know there are a lot of people behind them, helping them, organizing this meeting, this congress, and setting up this FOP association in Russia. Congratulations. I think it's really something what you did, and congratulations. As Fred Kaplan said, we met Vladislav 2 years ago in Germany, and we were speaking about FOP association, and of course we said, yeah, well, you have to do it. But I think whether Fred nor me, we thought that within 2 years' time we would stand here in Moscow and speaking to FOP community. Congratulations. You can really be very proud for this achievement. And I welcome you in the world community of FOP. I often say it's a very bad disease. And one fact why it is bad is that it's a very rare disease. And most of the patients in the beginning, they think they are the only one in the whole world with the disease. But this fact that it's a very rare disease has something good for us. Because when it's rare, you have to communicate crossing the boundaries. Yeah, you have to talk to somebody from another country. And this is very good. We have to unite over the boundaries. We have to form one big family, and actually we are already one big family. The father is sitting here in front of you. And we are one big family all over the world. And I welcome you to join us, and you will see there is a lot of positive thinking, a lot of positive experience from this group. And I think we could give the rest of the world a good example how people over the boundaries can communicate, can love each other, and can behave like a real family. So I think we should be a good example for all the politicians in the world and for all the places where there is still war. Yeah. Okay, now we can go to the more difficult part of my presentation. Unfortunately, Vladislav asked me to give a talk about POH, which is quite a very peculiar, quite peculiar disease. It's very, you said FOP is very rare, and it's still much rarer when it is, say, 1 people from 2 million people with FOP. You have 1 people from 20 million people with POH. So it's a very rare disease. And you might understand why most of the doctors, or almost all the doctors, they don't know the disease. From the first slide, you might see this is the place where I'm coming from. Unfortunately, it's difficult to recognize. This is a high mountain. This is the highest mountain in Germany. On the back from the hospital, it's 3,000 meters high. So we have a lot of mountains around, and this is a ski run, a typical ski run. Okay, so when we compare these two diseases, you know the abbreviations, the acronyms, FOP, from fibrodysplasia ossificans progressiva. Very similar, you have POH, progressive osseous heteroplasia. So this was a term which was first used by Rольf Kaplan. You might see here, this was his first paper in 1994. You might see that Rольf Kaplan and Michael Zaslow, you saw pictures from him. These two guys, these are actually the fathers, or the fathers of the disease, you might say. Yeah. So I said it's a very complicated disease. So when I would like to make it short, what are the similarities, what are the differences? I could say in one sentence, the similarity is that both diseases start in childhood, usually in small kids. Not always, but in general. And both diseases have a progressive heterotopic ossification, progressive, meaning it gets worse and worse and worse and worse. And both diseases have a genetic background, they have a mutation. So now I could stop. This is all of the similarities. Everything else is different. So for somebody who is tired, he can already go. He knows the main important things. But for somebody who is interested in the details, I will go ahead and give you some examples. Just for the interpreters, I am speaking too fast. Okay, good. Because they told me they have a hard time to translate when I'm speaking too fast, and I promised to speak very, very slowly. Okay. This is, you all know it, a typical FOP child. In the beginning, when they are young, you normally would just see the bumps on the forehead. Yeah? This is very typical, sometimes on the neck as well. And of course, you saw it so often today, the big toes. For all of us, it's very, very simple now, but you wouldn't think, most of the doctors, they would never look at the toes. They will examine the bumps and do X-rays, MRIs, CT scans, everything, but they would never look at the toes. So they would misdiagnose in many, many cases. Okay, and when you look at the young ones already, they would say we only have the bump and nothing else, but when you look at them carefully, and when you check the function of the cervical spine, you often will see that they cannot extend the head properly, or they cannot flex the head properly. And when you ask the parents, they say, oh yes, they noted it already when it was some months old, and they get a special therapy, physiotherapy, because they thought it has to do something with the brain, with the development. Yeah? So it's quite often, but nobody asks the parents, was there anything abnormal with the spine, for example? Okay, and then of course you have at the back this tumor-like swelling in FOP. You would never see in a POH patient. Just from within 24 hours, there's huge bumps and they can disappear in a very short time as well. Here you see them proceeding. And of course, we saw already X-rays from the big toe. You have this malformation of the big toe, and sometimes from different other toes. For example, here you see the malformation from the first digit in a hand, and you see it's much shorter. This bone here is much shorter, and you have a fusion of the joint here. And here you see the middle phalanx is very, very short. So it's not only the first digit which is affected. You might find some other malformations. This is another X-ray. You see how short this first metacarpal can be. And we saw already X-rays from the fusion of the spine. So when you do X-rays, the lateral view from the spine, you have this typical fusion, but this you can find in other diseases as well. It's not specific for FOP. Okay, and when you look at the chest X-ray, this is from a patient at about advanced stage already, in a very fast progression of the disease. You can see the scoliosis usually, and you can see true spine. Yeah? This is just all additional spine high up there, and it's completely different to what Nikishina said already, to the dermatomyositis where you have calcifications. Calcifications, they sometimes look like spine, but this is just a calcification, it's no bone. Whereas when you take a biopsy from this, you find a true bone, just a normal bone. This is a big difference. Many doctors, they don't know the difference between calcification and ossification, okay? So this is another reason why they make a misdiagnosis. Okay, so another example of a big bone. Unfortunately, you can hardly see it, but you can better see this bone here. And in addition, you have malformations of the hip very often. Very often the column of the femur is much broader, and you have coxa valga, we say. It's not the normal angle you have it. So, but you must know it, and when you check it, you can see it. Here you see it as well. This is an additional effect because there's a slight ossification there, but you can see it's a much broader neck of the femur. And when you have once watched Dr. Kaplan examining FOP patients, you saw him kneeling and you saw touching the knees, and then you know he was looking for these osteochondromas. You can feel them very, very easily. Yeah? It's no problem just to feel it, but you have to think about it. You have to know that there are osteochondromas. Most of the patients, they have these osteochondromas. Okay, so when we summarize, this is from a table from Fred. When we summarize, we see, of course, in say 95% or more, this malformation of the great toes, of the thumbs in 50%. We have the progressive heterotopic ossification, but this we have in POH as well. And the characteristic anatomic patterns, you saw already some slides, that it progresses from the head down to the toe, from the back towards the ventral parts, for example. And you have the fact that it's getting worse by when you injure the muscle. Yeah? When you get an injection, for example, when you use a knife, when you make an operation, it always gets worse. And you have the typical orthotopic fusion of the spine. We saw the osteochondromas. Often they have problems in hearing with the ossicles from the ear. And we have these typical swellings, mainly in the back in the beginning. And we have this progressive immobility and later the problems with breathing. So, from these features, we see all of them in FOP, and in POH we only see this progressive heterotopic ossification. So there's only when you examine the patient properly, already by examination, you could see this is real FOP. Without any genetic mutation, you can say this is FOP. This is a classical FOP. Or it is not. And in POH, you only have this progressive heterotopic ossification, but you would not have all the other features. So it's already not so difficult to make a proper diagnosis just by examining thoroughly the patients. Now this is POH. You, just at the first glance, you see this is different. The skin is completely different. Here you see that there are some skin problems. It's in the beginning sometimes like a rash, small macular, small patches, red patches, and you can feel it's a bit harder when they are older. These patches, they are darker, the color changes, and getting on, they coalesce, they grow together and form bigger plaques, and they go in the depth. They go down in the tissue. They go down. They start in the skin or subcutaneous tissue, and then they go down into the tissue, down to the muscle, and deeper. And they don't respect any anatomical borders, like a malignant tumor. What you would never have in FOP. They don't respect any borders. They just go through. Here's another boy with this skin. You can see it better on this slide, I think. This maculopapular rash, we could say, but it's a permanent rash. It's a permanent. It's not within only lasting for 2 or 3 days. it's permanent. Or sometimes it can be very little. Yeah? When you look at the skin, you wouldn't see very much. Here you just see a scar, and the skin more or less looks okay. But when you touch the scar and when you touch the tissue here, you will feel it's very hard. There is some hard substance below. And when you do an ultrasound, most of the pediatricians, they have the ultrasound just next to them. I say ultrasound is the third hand from the pediatrician. You might see this echogenic structure here. All bone, all what is white here is all bone, directly under the skin. You see this is 0.4 centimeters, so 4 millimeters, so almost 2 millimeters under the skin, the bone starts. Very easily detected by ultrasound examination. And of course, when you do an X-ray in the conventional manner, you will see this funny picture. It does not look at all like a FOP. Yeah? It's more cocoon-like, like a web, like a spider who has made a web of bony substance there. Here you can all see, I think it's more like a web. It's not a clear bone, as you have seen in the beginning. And here you see you have like a cloud up there with the white clavicular, and the rest is normal. This is something else which is typical for POH. You might have it only on one small part of the body. You might only have on one half of the body. We say hemimelic appearance. So this is quite interesting. Just this part of the body and not the other, which is clearly different to FOP. Here again, you see this older patient on the foot. You see this cocoon-like web. This is from the side. You have the web here, and then you have small nodules. It's difficult now with the beamer to see it properly, but you see a lot of small bones, like pearls, you could say, like small pearls. And this was a 13-year-old boy, one of the first I saw with POH. You can see the patella here. Here it looks normal, but you see there is something. And when you have the X-ray, from the lateral view, you see on the left side where it looked normal, this is not normal. This is the normal patella, but down there are some small ossicles, clear ossicles, ossification, but it does not look normal. And when you look at the other side, you see it's completely different. It's well, again, like a cocoon, like a web. And the MRI just shows it a bit better, you might say, with all the different structures. And you see like lamellar bone. I don't know if you have in Russia something what we call in Germany strudel. It's a dessert you can eat, and it's made with different strudels with different layers. And somehow this always reminds me of strudel, the different layers of bone. And when you look under the microscope, it's an intramembranous ossification. FOP we saw from the picture from Fred and Nikishina, it's an endochondral ossification. This means there was first cartilage, and the cartilage was removed, and then the bone cells came to replace the cartilage. This is most of our bones in our body are made this way, that there's first a scaffold, a cartilage scaffold, and then the cartilage is replaced by bone. Whereas this is a different way to form bone. We call it an intramembranous ossification, and you can verify it under the microscope. So when you have a biopsy, you can verify it under the microscope. Okay, now before it gets very complicated, we have to deal with another rare disease, which is called Albright's hereditary osteodystrophy. because there are some similarities with this disease. Originally it was described as people with mainly female, women short, about 1 meter and 40 or 1 meter 50 high. Most of them a bit obese, most of them with a round face like a moon, we say moon face. They had sometimes, not all, but some of them, they have some kind of mental retardation. They are a bit handicapped, mentally handicapped. And you see, sometimes they have malformations of the digits. Some are short, like in FOP a bit. Here, for example, the metacarpals are very short. This is why instead of having a dimple, instead of having a knuckle, they have dimples. You can see. Why is this disease similar to POH? They have some problems with calcification. Sometimes they have a little small nodule of bone in the skin. But normally it's no big problem for them. And when we come to the gene, we know that the genetic defect is somehow in relation to these other defects. You will see through with the next slides. But before we come to this, there's another rare disease which can be mixed up with here. This was a boy who came to me and he said he has a plate there inside. And when you feel it, with the finger inside, it was a plate like this just under the skin. Just a bony plate under the skin. And this is the same. You wouldn't see it, or you would see some swelling here, but you wouldn't see it. Which is a localized ossification. Sorry? 5 minutes? But these are not the 40 minutes we said, okay, it's your choice. It's your choice. Okay, so, but we have to know this, because this has something to do with all these orders together. Now here you have a paper from Kaplan and Shaw from Eileen. You might see just the differences and the similarities, and most of them we had seen already. And you see this AHO, this is somehow similar. They have this ossification. Actually the gene is not yet there, it was an older paper. And what I didn't tell you is that the AHO, this all-white hereditary osteodystrophy, they often have hormone problems, hormone resistance, so the calcium might be low, the phosphate high, and they have unresponsiveness, for example, to the thyroid hormones, to the TSH. So you always have to check the TSH and the PTH and the calcium and the phosphate to see if there is something. And here, it's older. This is why genetic mutations, unknown. Meanwhile, we can say we know it. This is the typical classical mutation and the variations we know from FOP. And we know, of course, meanwhile, we know the mutation in POH as well. So you can make a genetic analysis and you will find the mutation. But you must know, not every patient with POH, not every patient has a mutation in the GNAS gene, which is the gene which is responsible. Only about 70% might have this mutation. So, but you can, by clinical findings, you can make your diagnosis, even when the mutation is negative. This is the GNAS gene with all the different locations. You see the POH, this is mainly on this exon 7 and 5. Well, this we will skip within this short time. This takes too long to explain. But you see there are a lot of other, or some other diseases mixed to this. But this is a bit complicated. It would take us 10 more minutes, and it was a wish to finish.
We make a little shot, okay?
We can skip this. So to make a diagnosis, you could use this, for example. You have this heterotopic ossification. You have a patient with a heterotopic ossification. You just see, is it superficial? Is it only the skin? Or is it progressive? When it's only the skin and over years only in the skin, it's no POH. It's more this osteoma cutis type. But when it's progressive, you have the POH type. And then the question is it somehow associated with features from the Albright's hereditary osteodystrophy or not? And you can measure this by measuring the calcium, the phosphate, the TSH, PTH, what I said, to see if there's a hormone resistance or not. Yeah? So you can differentiate the different diseases, but we are in a hurry. Okay, I think the main thing for you might be, it might have been now a bit too much for you and too fast for you. So when you are interested, okay. Okay. So when you like to know more about this disease, when you are interested, I think it's a very interesting disease. It's like a crime story. So when you are interested in this disease, it's easy on the FOP, on this website, on the POHdisease.org website. You can download this POH family guidebook, and there is with just a very simple language, simple explanations. You can find everything more or less what I said. You can find it there in this booklet. Yeah? And everybody with internet has access to this booklet. Okay, so at the end, best wishes, a lot of wishes from everybody from Germany, from the German FOP Association. They were very thrilled to hear that you are forming, or that you have formed already such a big FOP association, and I'm sure they are looking forward to see you once in a common meeting, perhaps a common European meeting or a world meeting like we had in Orlando or in Philadelphia, for example. Okay, this was it. Thank you very much.
Мне пристыдили, мне теперь неудобно, что я прервал лекцию. Давайте, друзья, наверняка есть вопросы какие-то. Мы можем помочь. А то полчаса было заявлено, мы все приготовились к получасу. Давайте.
Еще раз здравствуйте. Вот меня интересует такой вопрос. Кто финансирует у вас в Германии, как я поняла, у вас исследовательский центр? Хорошо. Во-первых, что вас лично привело к исследованию вот этих заболеваний? У вас в семье кто-то или как? И как у вас в Германии проходят вот эти исследования? Кто финансирует их? Как собираются вот такие больные, да, люди? И входит ли у вас вот в стране это заболевание, и вот вы перечислили еще вот два, я не знала, не слышала о них, в состав редких заболеваний и государства? Как оно помогает?
That's a good question. For me, it was a bit. Well, I could say, to make it short, I could say FOP, POH is a hobby for me. I'm a pediatrician, but I'm not in my daily work. I'm not dealing with this disease. But like Niki Sheena, I was working 25 years in a hospital for rheumatic disorders, actually in the biggest hospital for rheumatic disorders in the world, in Garmisch-Partenkirchen. So I always did both. I was a pediatric rheumatologist and I was a general pediatrician. And but my part was mainly neonatology and operating and things like this. But then I got a patient. The one you saw on the first slide, and he was 1.5 years old, and he had the funny swelling on the head and the funny swelling on the neck, and of course the doctors didn't know, they had no idea, like always, and they said, we have no idea, okay, we cut out, we need to make a biopsy, we get a sample from the tissue, and we examine it under the microscope, and then we know the disease. And but under the microscope it looked somehow peculiar, funny. They were not sure, and then somebody said, "Oh, it's a Weber Christian paniculitis. This is a very special rheumatic disease." And they said, rheumatic disease, I know there's a hospital in the Alps in Garmisch-Partenkirchen, we will send them there. This is how it came. And they said it's a rheumatic disease, and I said, I don't know what it is, but it's no rheumatic disease. And then I said, okay, we all learned in medical school we should examine the patient from the toe up to the forehead, the whole person, not only the lump. So we started at the toe, and we said, "Oh, what funny toe! Have you ever seen such a toe?" From adults we know, or from older people, but we never saw such a toe. And we said, perhaps this might have something to do with the bump there. And we looked up the books, and then it was very easy. We found in Germany it was called Münchmeyer syndrome, this fiber dysplasia. And so we knew the disease, and then we said to the mother, this is the diagnosis. And we said, okay, but how can you help me now? What shall I do? But I said, well, we deal only with rheumatic disease, but there are specialists for this disease. You have to go to a genetic institute in Germany. Yeah? And okay, she said, okay. Then she went to a university, to the next university, and to a genetic institute, and they saw the child. And then 2 days later, the mother phoned me, and I said, and she was crying. And I said, why are you crying? Was the diagnosis not right? No, the diagnosis was perfect. They said, that's it. And then I said, yeah, but why are you crying? Yeah, well, I wanted to know what I should do. And they said, it's a genetic disease. There's nothing what we can do. Just go home. And I said, this can't be true. Somebody must help you. And this is how my FOP business started. Because then I got in contact with the mother, in close contact. It's Petra Sommer, you know her. And I told her, like I told Vladislav, it would be good to have an association. And we found more and more patients. And the biggest luck was that I found the father of the disease here, sitting here, Fred Kaplan. And so we had a lot of patients with him, not a lot, but most all of the patients in Germany, and patients from Italy, patients from France and Denmark with these kind of diseases. And we just tried to make the best, but there was nobody financing any, like what your question was, financing any research. Only by Fred Kaplan we knew that they had some kind of private financing by fundraising, just by getting money from the people and financing. And meanwhile we do the same. We have fundraising in Germany, and we support the group in Philadelphia, and in Berlin there's another research group, a smaller research group in Berlin. But from the state, there is so far no money from the state.
Спасибо большое. Можно по-русски, правда же? Я доктор. Мой вопрос очень простой. Как вы можете помочь этим людям сегодня?
Today. Well, this is an important question, because most of us have the feeling there's nothing I can do. But there are a lot of things you can do. The first one is to teach, to prevent that doctors make the disease worse. This is very, very important, because we all see patients who became worse because of the operations, a lot of operations they did. So the first one is to teach. The second thing is we can unite and exchange our experience. Every patient has a personal experience. We can exchange what was good and what was bad. For example, did physiotherapy help me? Did diclofenac gel rubbing in, applying, did this help me? did corticosteroids, did they help me, and things like this. And the third is, as I was working as a rheumatologist, and we saw that the first phase of these FOP lesions, the first phase is an inflammation. Then, of course, we can use our knowledge to stop inflammation, because when we can stop inflammation, we might make it better. So normally, most of the rheumatologists, they have a lot of knowledge about to deal with inflammation. How can we stop inflammation? How can we apply a corticosteroid? Can we apply it only orally? Can we give it in a higher dosage, kind of pulse therapy, and things like this? Do we need continuous treatment? Do we need only short treatment? Things like this. So this already helps. So some patients, for example, when they overnight, the jaw might be locked. And they phone me and say, come as soon as possible. And then we do an IV corticosteroid pulse therapy with much higher dosage than the oral. You saw the dosage was 1 to 2 milligrams per kg. We use about 20 to 30 milligrams per kg, but intravenously as a pulse therapy. And in some cases, they could open it on the jaw. Yeah. So there's already now are things you can do. Okay?
Огромное спасибо.